Welcome, everyone. I am Dr. Laurel Barr. I am the chair of the Early Career Physicians section, formerly the Young Physicians section. And I am here today with the past chair of the Pain Management and Addiction section,
Yeah.
Dr. Ruben Strayer. Dr. Strayer, thank you so much for being with me here today.
Yeah, it's great to be with you, Laurel. I'm glad to represent the section.
Can you tell me a little bit about yourself, your role in the section, and how you got involved?
Sure. I'm an emergency physician. I've been an emergency physician for a long time now, more than 20 years. And in the past, I'd say decade, the second half of my emergency medicine career, I became very interested in pain management and specifically in opioid use disorder. And I found the ACEP pain management addiction medicine section to be a natural outlet to further those interests. So I got involved, got interested in advocacy, got interested in programming, started attending the meetings, and before I knew it, I was involved in leadership of the section, and I led the section as chair for 2 years, and have handed over the chairmanship to Dr. Rachel Harrows.
The mission statement for the section is to advance safe, effective, and evidence-based care for patients with pain and substance use disorders in the emergency setting, expand ED-based addiction treatment access, improve pain care while reducing harm, support physicians through education and advocacy, and represent EM in national conversations.
Yeah, I mean, it's a broad mandate. We cover a lot, and we may be splitting up into two sections shortly. We're very excited about that as the specialty has matured, the addiction specialty and the addiction subspecialty within emergency medicine. We have found that there's really, it turns out to be two separate areas of interest: pain management and addiction. As of now, they have a home under one roof in the pain management and addiction medicine section at ACEP, and we've been pursuing a broad agenda that you just outlined. Soon, the pain management part of the group is going to separate off into an interest group and then hopefully their own section, as there's now really two separate tracks as subspecialties that emergency physicians can pursue: pain management and addiction medicine.
I noticed that was one of the goals for the next year of the section, and I think that's a great idea because the two things do use similar medications, but are very, very different things and different goals of treatment. So that's
100%.
wonderful.
So for addiction management, addiction medicine is the science art of treating people with substance use disorders. Pain management, of course, has a separate set of goals and has to do with managing people in pain. There's a lot of overlap, especially around opioid use disorder, which is why the two interests are housed under one roof right now. But like many things within the domain, we've seen the maturation of the fields so that people get more and more specialized, which is great as people develop their own domain expertise. And there's now a groundswell of pain management emergency physicians who are ready to tackle a really subspecialty specific agenda, which is why we're moving in that direction.
Yeah, that sounds excellent. I'm sure, just like you, I've never encountered a patient in pain in the emergency department.
It's something that we're dealing with, of course, with almost every patient, if not every shift. And it turns out that there's just a lot of nuance in managing both acute and chronic pain. So it's wonderful that we have a venue to explore the nuances of pain management within ACEP.
And I love that your section puts out clinical policy statements and other documents that you can really use on the ground during a shift to kind of treat and start, and how to start Suboxone clinics, or sorry, not start Suboxone clinics, but start before buprenorphine induction in the emergency department and get them to places where they can continue that. Because it's really helpful. There is actually a whole bunch of different things in the literature that I discovered as I was training, and really sifting through that and figuring out what matters the most is great. So can you tell me about the policy statements and other resources that the section puts out so that we can help these patients on shift?
Yeah. So just focusing on the addiction medicine side, buprenorphine has been one of the mainstays of treatment for opioid use disorder for many years, but has until fairly recently not been in the emergency physician's toolbox. And one of the primary drivers for the section has been to educate emergency physicians on the use of buprenorphine to treat OUD, and to put in place a set of guidance documents that pit docs can use on shift to identify patients with OUD and then initiate the proper treatment. This is a rapidly evolving space. Buprenorphine is a miracle drug in the treatment of OUD, but has limitations, has cautions, and the use of buprenorphine has changed as the drug supply, the street drug supply, has changed. Using buprenorphine, initiating buprenorphine has become more challenging as heroin has been replaced by fentanyl, and it requires specific strategies. And so we've been very active in developing resources to help emergency docs navigate that landscape and make good choices for patients they see in the ED with OUD.
Excellent. And just another reason or example of how we can safely and effectively use these medications to treat patients at their time of greatest need. Whereas if they're not used safely and effectively by physicians who know what they're doing, can lead to harm. But luckily we can mitigate that and we can start these patients on the right pathway.
100%. There's, of course, another very important treatment for OUD, which is methadone. Emergency physicians have, I think, even less comfort with methadone than with buprenorphine. And federal legislation now allows many jurisdictions to dispense methadone from the ED under the so-called 72-hour rule. And so one of the projects we're going to be working on going forward is educating physicians, emergency physicians, on how to initiate methadone in the ED and then potentially send patients home with a couple of days supply to bridge them to the methadone clinic where they can get ongoing OUD care.
Aside from putting out the policy statements, what does the section help to advocate for, to educate for, networking opportunities? What other benefits are there from being a member of your section?
We offer a variety of benefits along the lines that you just mentioned. I think one of our most important benefits, one of the things we offer that is of the most help to especially young physicians, is a network of addiction and pain management experts who are excited to engage with physicians who are trying to, number one, figure out how to treat patients with OUD and pain and other addictions in their practice environment. Number two, trying to develop a niche within the specialty. There's a lot of emergency docs who are coming out of residency, they get involved in community or academic practice, and they want to develop programming locally within their own departments. And the section offers a wealth of guidance as well as a lot of folks who have been down that road and can offer a lot of support and resources to help emergency docs who are looking to develop domain expertise in addictions and pain management, move that interest forward.
And I hear there was recently a member among the section who used the resources of the section to really start a addiction clinic in their area. Dr. McNamara?
Yeah. So as an example, Liz, a junior emergency doc, I guess not the junior anymore. She was my resident a long time ago. She reached out to me to help guide her on navigating both clinical and political challenges in her relatively remote environment in California, where she was trying to move forward a lot of addiction programming. And she'd run into a number of roadblocks, and I basically availed her of some of the section resources, and she used some of that expertise and some of the contacts that the section offers to further her interest and navigate some of the challenges she had been facing locally. And she's still working on that. There's a lot of work to be done in her section of the world, but she has been able to effectively, I think, use the section's resources to move forward her own career and to advance the interests of patients with substance use disorders locally.
Excellent. I can only imagine all the barriers that might come to the top of mind in the first 5 minutes when I'm thinking about opening up one of these things. But I imagine there's way, way more that she had to encounter. And it's great that other people have done that before and they've crossed those barriers, and really having that experience, that knowledge, and really that playbook that the section provides has got to be a great resource.
Indeed. We have champions from across the country who have experienced all sorts of roadblocks in treating patients with addiction, both on the patient side, in the department side, on the hospital side. There's also regulatory challenges, regional, national, that all have to be dealt with. And fortunately, this is a path that we've traveled down before. And for especially young physicians who are interested in walking down that path, we can lend a hand.
And I'm sure just with the patient types we see in the emergency department, this is going to be something that piques the interest of many early career physicians just because of the populations that we see and how widespread this is and just the tragedy associated with it.
Addiction is a very important source of morbidity and mortality in Americans across the country, and presents very unique challenges to emergency clinicians who are often at the tip of the spear in managing a chronic problem with acute consequences.
Kind of like trauma. It's a chronic problem with acute exacerbations.
Yeah, and there's of course a lot of overlap, especially with respect to alcohol use disorder and drunk driving. We see a lot of the sequela of substance use disorders play out in the emergency department. We have been pretty good about treating the sequela of addiction over the course of the decades-long course of the specialty. We haven't been as good at treating the addiction itself. So with respect to alcohol, for example, managing trauma, managing withdrawal is a fundamental emergency medicine practice, but we have not done nearly enough over the course of the specialty's development to address alcohol use disorder, even though we have what I call the front row seat to the saddest show on earth on every shift. Treating the withdrawal without treating the underlying problem is only a patch, and we've learned, given our experiences with opioid use disorder and how effectively we can act as a touch point for patients with OUD, initiating them on very effective treatments in the ED, recognizing that the ED is often the only point of contact these patients will ever have with the healthcare system. We've embraced that role, I think, collectively, and we're using some of those lessons to change our approach to other addictions that we see constantly, like alcohol use disorder and also nicotine use disorder, which is very prevalent, extremely dangerous, causes massive morbidity and mortality, and is also highly treatable.
Well, you've convinced me that there's a problem that needs solving. So what are the initiatives of the section going forward, the goals for this year and beyond? What can we look from the section going forward?
So we have a variety of issues on our plate. The regulatory environment continues to shift nationally, federally, with changes in federal leadership. We are navigating programs being reduced, programs being canceled. The drug environment on the street is changing. So we're constantly responding to a shifting landscape of intoxicants. For example, what used to be heroin is now fentanyl. What used to be fentanyl is now fentanyl contaminated with xylazine, or more recently, medetomidine. This, in some areas of the country, has produced crazy withdrawal symptoms that many of us were not trained to recognize or treat. So we're trying to get the word out. We're trying to offer clinicians toolkits to manage these new intoxications and withdrawal symptoms. We're interested in regulatory changes around the 72-hour rule, which I just mentioned, and how emergency docs can now potentially dispense 3 days supply of buprenorphine or methadone to patients, and we want to offer resources to help folks do that. We are very interested in developing the pain management side of the pain management and addiction medicine section, and as I mentioned, we are looking forward to pain management having their own forum and further developing that in collaboration with the addiction folks. So there's a lot of us who do a lot of both, but that's going to be a major priority for the section over the next year, is separating out the pain management side and giving them a space of their own.
Certainly a very good initiative. And you know what, as I hear you talk, I'm just hoping for a future where we've gotten so good at the pain management that almost the substance abuse side becomes less and less. That would be amazing.
Addiction physicians would love to be so successful that they become obsolete. I think we're a long way away from that ideal outcome.
I can dream, can't I?
100%. Yeah. Maybe we'll get there one day.
I think you're probably secure. I don't think substance abuse in general for everything will ever go away because we are humans and we're always looking for solutions and we're going to find those whenever we can. But it would be amazing if we have so many pain management techniques that are specific and effective and we look for the sledgehammer less and less.
Agreed. The pain management landscape is shifting. We have our first new analgesic class in decades. So Jornavex, which is suzetrigine, is coming to an ED near you. This operates in a totally different way, and pain management experts are trying to figure out how to harness this new class of analgesic agents. The addiction landscape is changing drastically over time. I mentioned how heroin has become fentanyl and is now contaminated with xylazine and metamidine, but we've now seen like a shift in tobacco use now over to vape nicotine and requires a different set of strategies. There are novel intoxicants. The one that's receiving the most attention is kratom, which is an opioid-like plant that is now available unregulated at head shops and gas stations across the country. These are producing really problematic addictions and withdrawal symptoms that are going to be coming to emergency departments. So the specifics shift from year to year and decade to decade, but the problems remain the same. And we've learned that emergency docs have to be fluent with the strategies, with the approaches to managing addictions, even if the substances themselves shift slightly over time.
Yeah, very good point. I remember a surgeon kratom a couple of years ago, and I was not sad when that went away, but I'm sure it'll be back as the network and the choices change on the street. What do you feel are the most pressing advocacy issues for your section right now?
We're always concerned about the regulatory and reimbursement frameworks that incentivize or disincentivize patient-centered, evidence-based care for addiction and pain management. So we want emergency docs to be able to initiate proper care for addictions and be paid for it. We want emergency docs to have access to the best analgesics in their departments and know how to use them. And those are the issues that we're constantly focused on. And as the laws change, as the regulatory environments change, we want to be able to understand what those changes are and interpret them in a way that makes sense for emergency docs. And we do a fair amount of advocacy. The 72-hour rule, for example, came into being in no small part due to ACEP's advocacy. And we continue to try to push forward an emergency physician-focused, patient-focused agenda regionally and nationally.
Excellent. I love that the priorities of this section has become major priorities for ACEP in general, resulting in regulatory changes that really changes the practice of what we can do and how we can help these patients.
It's remarkable to consider how far we've come as a specialty in the management of addictions in particular. A decade ago, very few emergency physicians had even heard of buprenorphine. And now, certainly all of my residents now think of the initiation of buprenorphine in the department to treat OUD as a normal part of emergency medicine practice, which is incredible.
What advice would you give to new members looking to join either pain management or the addiction medicine section if we're going to split them into two?
All right. Well, at the moment, we're still under one umbrella. We're hoping that, again, pain management will have its own forum soon, but get involved. The barrier to entry couldn't be any lower. Join the section. We communicate via an email list, which is where most of the meat of the section networking occurs. So join up, get the emails, join onto the list where we discuss whatever problems come up day to day in addiction and pain management practice. There are a variety of of initiatives that sort of flow across the section as documents need to be reviewed, policies need to be developed, new programming needs to be produced, and these opportunities filter across the email list frequently. Join on, sign up, get involved, and carve out your own space, develop your knowledge in addiction, pain management, or both. These are really interesting, highly dynamic domains within emergency medicine. We need experts, we need leaders to move the specialty forward and the subspecialties forward.
So it sounds like certainly a unique opportunity within the section with it changing just the nature of the substance abuse and the substances changing sometimes day to day, sometimes month to month, really getting that information out up to date, a great opportunity for some involvement even at the lower level to really make a big impact across the specialty.
100%. We want junior, mid-career, senior emergency docs involved, engaged. We're a welcoming group. Sign up and get involved.
Anything else you'd like to share with the group today?
No, thanks for inviting me on to speak about this. Both addiction medicine and pain management are really important, really dynamic domains and subdomains of the specialty. We need people to be experts in guiding their teams locally and nationally. And the ACEP addiction and ACEP pain management addiction medicine sections are great forums to do that.
Excellent. So if you're looking to be an expert, if you're just looking for the tools to help a specific patient, these resources are great. Easy to get them. Join the section, join up, just click the box when you go into your profile and then sign up for the emails and get that up-to-date information and get involved wherever you can.
Looking forward to meeting all you guys. Thanks, Laurel.
All right. Thank you.